Hello and welcome back to the video. You've joined myself, Dr. James Gill, for another clinical skills video. Today we're going to be doing a deep dive into the examination of the hand. So to start off with our examination, we need to introduce ourselves to the patient and make sure we've gained adequate consent. Hello, my name is Dr. Gill. I've been asked to do an examination of your hands today. Before we start, can you please confirm your name and date of birth?
Yeah, my name's Megan Struthers, and 22nd of February 1998.
Super. In terms of doing an examination to your hands, that's going to involve having a look at your hands. I'm going to be moving your hands and I'm also going to be squeezing them and getting you to do some movements that might be a little bit uncomfortable. Are you happy with that?
Yeah.
Super. So before we start, can you tell me if you're right or left-handed?
Right-handed.
Super. So in terms of that consent at the beginning, it's very important to highlight that actually, because our hands are our most sensitive parts of the body, actually doing the examination, particularly if there's pathology in the hands, such as rheumatoid arthritis, we may end up hurting the patient, which is something we want to ordinarily avoid as much as is possible, but might be unavoidable, for example, when we come to squeezing the metacarpal phalangeal joints. We've also identified if the patient is right or left-handed because we may find things like carpal tunnel being perhaps more common on their dominant hand. So to start off, we want to have a look at the patient's hands. So if you could put your hands on the pillow for me, and we make sure that the pillow has been, we've got one of the antibacterial covers, but nevertheless we wipe it down between each patient. So we're having a look at the wrists to start off with, to see if we can see any obvious swelling. We're looking over the back of the hands to see, can we see any calluses, any evidence of deformities, and again over the fingers to see if we can see swellings at the proximal or distal interphalangeal joints, and again looking at the nails, given that we know that there's a huge number of things we can see in the nails that can identify other issues within the body. We're going to cover the same observations on the opposite hand as well. We get the patient to turn their hands over, and then we're going to have a look over the palms. We want to see if there's any evidence of scars at all, such as we may have seen with the carpal tunnel release. We want to have a look to see if we can see perhaps any thickening on the palmar aponeurosis, so Dupuytren's contracture. But in the early stages of that, we may not actually be able to see the thickening, and we may actually only find it on palpation. Conversely, we may find very extensive Dupuytren's contracture where the fingers have actually become deformed and have been pulled inwards. We want to have a look to see if there's any obvious change in the position of the hands and if there's any wasting of the muscles, for example, the thenar eminence with median nerve compression, or perhaps the small muscles with a T1 nerve compression, or the interossei with an ulnar nerve compression, perhaps from a cubital tunnel syndrome. Now I highlight that because we also need to have a look and get the patient to move their arms up, to have a look at the backs of the elbow, the ulnar border, and if you move your elbows forwards please. And we're having a look to make sure we can't see any evidence of psoriasis, and at this point we can start putting our hands on the patient with consent. So I'm just going to run my hands down the border if that's okay. So again, running down to see if I can feel any potential rheumatoid nodules, any bruises, anything like that. If you put your hands back on the bed. And from here, we're going to carry on with the palpation. So we're going to start off on the wrist. We're pressing over the ulnar and radial heads, particularly checking if there's any discomfort of the radial styloid. We're going to slightly raise up the hand and we're going to press along the length of each of the long bones in the hand, and then coming round to the thumb. We can press and turn the thumb to see if we're getting any pain that we might associate with osteoarthritis at the base of the thumb. Looking over the MCPs, we're going to see if there's any warmth to them or any erythema, and we can then squeeze over the MCPs lightly. Does that cause any discomfort?
No.
So that inflammation or swelling and certainly discomfort might give us cause to think about rheumatoid arthritis or an autoimmune condition. We then want to carry on looking over the fingers with the proximal, so the first joint, and the distal interphalangeal joint, the last joint on the finger. To look for swelling there, we're going to box the fingers. So we're pressing from the side and the top and bottom, both sides, making sure that we're covered the small joints all the way around, and we're trying to find if there's any evidence of inflammation, swelling, bogginess that might suggest synovitis there. We do the same again on the other hand. So again, feeling along the phalanges, checking over the MCPs, so giving them a squeeze, boxing all of the joints, and again seeing if there's any evidence of discomfort at the base of the thumb that might suggest some arthritis. At this point, we can also, if we want to, get the patient to raise their thumbs up slightly, and that will cause the anatomical snuff box to become apparent. This is a very important anatomical location because it's the location whereon the scaphoid bone is just palpable underneath. And we want to give that a slight press to see if there's any pain or tenderness there. Any problems there?
No.
Now, it's something that you can do on yourself. So if you raise your thumb up, you can see the two ligaments appearing. If you press in there, you'll feel sort of a bony hardness. That is the scaphoid bone. And if you give it a good poke, it's a little bit sore. However, if you had a fall, so a fouche, fall on the outstretched hand, that can cause damage to the wrist, but it can also result in a fracture of the scaphoid. So in patients with discomfort, pain in the anatomical snuff box, we'd do an x-ray certainly. However, we may not see any changes even if the bone has broken. So once we've diagnosed pain to the anatomical snuff box, we must return for a second x-ray in 2 weeks' time to see if we can now see any evidence of a fracture. This is very important because the scaphoid bone is unipolar in its blood supply. So if the scaphoid fractures across the centre, then it cuts blood supply to the other half, which would mean if the bone heals without uniting, we can get osteonecrosis, so death of this very important bone in the hand, and that can cause significant problems for both the wrist and the thumb in later life. It's so important, if we're still getting pain in the anatomical snuff box after the second x-ray, it's not uncommon for an MRI to be performed to double check that there's no problems with the scaphoid there, because it's such an important bone. From there, we're going to carry on with the palpation on the opposite side of the hand. And here we're going to again press the base of the thumb, and we're making sure that we've got a good muscle belly. We can't feel any fasciculations that we might associate with a lower motor neuron lesion that might be in keeping with median nerve compression. We're going to feel along, putting some degree of force across the palm, specifically feeling if there's any signs of a thickening on the side of the palm in keeping with Dupuytren's contracture. Again, we're going to feel along the underside of each finger, specifically to see if we can feel any swellings to the tendon sheath, which might be in keeping perhaps with a trigger finger. We'll do the same again on the opposite side as well. And whilst we haven't found any abnormalities, at this point we're going to get the patient to make a fist and then relax. So we haven't felt any swelling that might suggest a trigger finger, and we've seen excellent movement there in the fingers. I'm now going to do the same, and I'm going to move the fingers, rolling the hand up and then back out again. So I'm confirming that there's no resistance. We've not got any stiffness to the fingers, which can happen after a simple fracture of any of the bones in the hand, where the hand has then been immobilized. That stiffness just means a reduction in range of movement. And doing the same on the opposite side, we're also making sure there's no evidence of crepitus, so this sort of crunching sensation in the bones that might indicate damage or wear and tear at the joints. Now, when we've been looking at the hands, we have mentioned issues with swelling to the MCPs for rheumatoid arthritis. If we're talking about osteoarthritis, if you could turn your hands back over for me, we're specifically looking for swellings at the distal and interphalangeal joints by comparison to the MCP joints for rheumatoid arthritis. These swellings are Hebrideans and Bouchard's nose and would indicate likely osteoarthritis. And they're differentiated from the swellings of the MCPs because with an autoimmune condition, the MCP swelling is boggy, it's soft, warm and potentially with some pain. By comparison, the swellings of osteoarthritis are hard and non-tender and shouldn't be mobile. Other changes that we can see on the hands, we may find particularly long, spindly fingers called arachnodactyly, which will be in keeping with a patient potentially with Marfan syndrome. We need to keep in mind that, as mentioned, looking at the nails, the hands are the gateway to the body. And if we were suspecting arachnodactyly, we'd then want to have a look for evidence of a high arch palate and perhaps an increased arm span. Again, all in keeping with the connective tissue disorder that is Marfan syndrome. Looking over the fingers themselves, we can actually see if there's any evidence of structural deformities. So we can have a swan neck deformity where we end up with hyperflexion of the distal interphalangeal joint and hyperextension of the proximal interphalangeal joint. Thankfully, because I don't have these deformities, I can't do it with my finger. But we can have the inverse, where we have a boutonniere or buttonhole deformity, where we have hyper extension of the distal interphalangeal joint and hyperflexion of the proximal interphalangeal joint. Other things that we can see in the hand, potentially with regard to rheumatoid arthritis associated with damage to the MCPs, are ulnar deviation, where the fingers are all shifted towards the ulnar aspect of the hand. And we also might get malalignment of the wrist if there have been fractures and things like that previously. One of the commoner sources of inflammation to the tendons is a de Quervain's tendonitis. So to assess that, we get the patient to raise their thumb up, very similar to checking for the scaphoid issue. However, we're going to press over the extensor tendons on the radial side of the wrist, checking for any discomfort there. And again, if you move that thumb up, and we can enhance that further by getting the patient to keep their thumb in this position and stop me moving it for you. So I'm pressing down, that's obviously causing forced extension. And if we had de Quervain's tendonitis, we get discomfort here. When it comes to getting the patient to put their thumbs and in different positions and do resisted movements, you can say, move your thumb here or move your thumb there. In many ways, such as we did there, if you could raise your thumb up for me, it's better to say, don't let me move your thumb, so the patient can easily concentrate on keeping their thumb in that position without having to work out what as medics we're asking them to do. So in terms of finalising the examination, we need to do movements. We've already done some, but we're going to repeat ever so slightly to double check things. So if you could, again, make a fist for me and out, and then bring the fingertips over the top. So we're looking to make sure the palmar arcades are normalised and that the fingertips are all pointing towards the radius. If we've had any evidence of fractures, then we potentially wouldn't have fingers pointing in abnormal directions. We're then going to get the patient to raise their arms up, and I'm going to, if you turn your hands over please, I'm going to isolate the wrist on this side so that movements will come from the wrist. And if you can cock your wrist up please. Cock your wrist down and back to centre and outwards for me and inwards for me. And if you flatten your fingers and extend backwards. Super. And we do the same again on this side, so make a fist for me. And all the way out, and all the way in, and back to centre, and cock the wrist up, cock the wrist down, and bring your fingers out, and flex them up for me. Okay. The other thing that we can do is we can put all of those movements together and get the patient to circumduct the wrist, going round in a circle. So I heard a slight bit of crepitus there, but I couldn't feel any with that. And we'll do the same again all the way around. Super. And that's useful because although the straightforward movements felt fine, on that point there was both audible crepitus, but I could feel it through my fingers as well. Now, in somebody who doesn't have any other abnormalities, that's probably going to be just a bit of strain from repetition, so perhaps a lot of writing or revision studying. In terms of the other movements we need to do, we need to start doing opposition. So, in terms of the fingers, so if you could move, we're going to look at flexor digitorum profundus, which will move our fingers in a plane. So if you could turn your hands over for me. We're going to confirm that flexor digitorum profundus is intact by isolating the index, ring and little finger, and then getting the patient with their middle finger to touch their palm and back out. So that's fine. We'll do the same again on the opposite side. Perfect. We're going to make that test a little bit more complex, as we're going to isolate all of the fingers to test flexor digitorum superficialis, and we're now going to get the patient just to move their fingertip. Super. And we'll do the same again over here. If we had, for example, an injury with either of those two tendons, then we wouldn't expect them to be able to perform those movements adequately. Keeping the hands palm up, we want to look at the movements of the thumb. Now, the movements of the thumb are particularly complex from a medical perspective, and that can cause issues with translation over to the patient. So we want to have, instead of asking the patient to do various movements, such as abduction or adduction, we're simply going to get the patient to copy our movements. So push the thumb out, and then in, and then across, and then rise it up. And we're going to do those positions, and I'm going to ask you to keep your thumb in that position. So don't let me move your thumb. Super. And if you could take your thumb out for me, don't let me move your thumb. Okay. If you could bring your thumb in, don't let me move your thumb. And if you could bring your thumb across, don't let me move your thumb. That's fine. So we've passed all of those movements very simply. Then we're going to do movements that are involving the radial nerve, the ulnar nerve, the median nerve, and the anterior interossei. So we can do that with essentially paper, scissors, stone, and OK. So the way we do the paper, so put the fingers out and spread your fingers wide as you can and bring them in again. That looks fine to me. Then we're going to do the scissors, so the ulnar, so hands like so, and moving your fingers in and out. Brilliant. Then we're going to do the median nerve, so making the stone. We've already got a good movement with that. And finally, we've done the OK sign. And we're going to now we want to test the powers with those. So I'm going to use my own OK sign, but I'm testing with the interface, pulling through and pulling through again. And the little fingers, please. And pulling through and pulling through. So there's no evidence of weakness. We're then going to check our stone, as it were. So now we're getting the patient to put the thumb and index finger on the paper. And if you do the same, and don't let me pull through. So we've got equal power, and relax for me. Now we're going to test our scissors, so ulnar nerve. So now it's index and middle finger on both sides, and if you could pull for me. Super. We're going to test the median nerve one more time by getting the patient to take both fingers and squeeze them hard as you can, tight as you can, and relax for me. It's very important we provide the patient with 2 fingers to squeeze. If we provide them with 1 finger, there's not enough girth to get adequate torque, so we can't identify how well they're squeezing the fingers. Conversely, if we give them 3, then there's too much space and we can get excess torque, and it's possible for the patient to break the examiner's fingers. However, with 2 fingers, that is not a worry and also allows us to adequately assess their strength. One of the other things that I've been observing during the examination is the effective movements of the hand. So we're getting effective pronation, supination, flexion and extension. Yes, we've identified specifically some of those movements, but it's also looking at the global movements the patient is doing. With regard to that, we need to make sure that we're treating patients as individuals and people rather than just boxes to be analysed. So with that in mind, whilst we haven't found any abnormalities here, if the patient had been complaining of pains to the fingers, we'd want to test some issues functionally. So perhaps get them to undo a button or pick up a pen. So that concludes our examination of the hand in terms of the generalised assessment. We do also need to add in a couple of special tests at the end with regard to carpal tunnel. So we get the patient to put their wrist backs together, and so they're essentially squashing the median nerve, and we're going to leave them like that for 60 seconds. Knowing that the median nerve innervates the thumb, index, middle and half of the ring finger, after 60 seconds we want to see if we get tingling in those areas. So, any issues?
No.
Okay. The other test that we can do is Tinel's test, where we get the patient to put their hands on the covers again, and I'm going to strike over the median nerve and seeing if we get shooting paresthesia, shooting pins and needles in that median nerve distribution, which we do on both sides. So any issues with that?
No.
Super. So we haven't found any abnormalities to your hands. Do you have any questions for myself?
No.
Super. So that covers our examination of the hand. We've stayed with the basic orthopaedic pro forma of look, feel and move. If you've got any questions about what we've done on the examination today, please put them down in the comments below and we'll try and help you. Similarly, if you'd like to subscribe to the channel, you can engage with us on the Communities tab and help us plan further videos. And if you like the video, at least it tells YouTube we're here. So thanks for that, take care, and we'll see you in the next one. Cheerio.